website. But anyway, I'm Sian Roberts, I'm a GP, and welcome very much to our webinar today, which is one of a series that we have been doing during COVID, and today is regarding dementia in care homes. And really, just to introduce myself, so I'm Sian Roberts, I'm a GP, I'm one of the dementia clinical leads for the South Eastern Clinical Delivery Networks, alongside two other colleagues, Dr. Chris Kipps and Dr. Bikram Ray Chowdhury, as well as our great supporting quality improvement leads, Joe Gavins and Rachel Chappell. So that's what we're hoping to do today, is about focusing on dementia in care homes. Have we got the slides up, actually?
I'll just share the slides.
Thank you. So we'll just share the slide. So yes, if we go to the next slide, if that's all right, Rachel, thank you. So today the agenda, we've got, obviously care homes have been a massive priority during COVID. Lots to talk about how to support those living in care homes. So today we're really just doing little parts of it, but very important parts. So we hope that this will be of interest. So it's about interfacing with care homes and how we can support the residents and staff to manage people to live well with dementia in care homes, supporting care home staff to become Dementia Champions, looking at how good oral health can impact dementia care, and as well as really a quick introduction to a toolkit that can support care homes in their self-assessment and delivery of dementia care. So that's the agenda. The next slide. So just in general housekeeping, probably all familiar with the webinar approach at the moment. Would really appreciate, we've got lots of people on this webinar today. So if you don't mind popping yourself onto mute, and also if you don't mind turning off your camera unless you're presenting. It just means that we get all the broadband as we should. Please do use, we like it to be interactive. So hopefully you can see the chat bar on the right side of your screen. Please use this to ask any questions throughout the presentations, or indeed make any comments. So we prefer to do it this way rather than people chipping in, because obviously there's so many people here. Just a reminder that the meeting will be recorded, and of course that it's this recording and the slides will of course be circulated to yourselves and of course anybody else who is unable to attend today. So next slide is just to say, so we've got some fantastic speakers who've come to talk to us today. So we're going to just chunk it up to about 20 minutes per session, 15 minutes for the presentation, and hopefully 5 minutes for a conversation at the end of that. And so my first, I'm delighted to introduce Dr. Katie Lee, who is a consultant clinical psychologist and the lead for the SABP care home pathway. And over to you, Katie.
Thank you very much, Sian and Rachel. Just to say, I'm having some problems with my Wi-Fi at home today, so if you'll forgive me, I'm going to turn my camera off in the hope that you can have a reliable signal strength. So I'll get started on that basis. Thank you. So lovely to be here today. I've been asked to come and talk about interfacing with care homes. I'm really just here to give a little bit of an overview of key facts and drivers in the care home system. And then I'll be going on to talk about the journey that we've had within Surrey and Borders Partnership in terms of dedicated care home pathway functions, before finally thinking about some of the challenges faced and next steps. So if we could move on to the next slide, please. So just a few key facts about the care home sector more broadly. We know that we have in excess of 850,000 people with dementia in the UK, and a significant proportion of those people reside in care homes and indeed receive some form of public funding support. We also know, as Sian highlighted at the beginning, that there are significant inequalities for people living in care homes. Often these people have very complex and comorbid mental, physical, cognitive, social care needs. And obviously there's a real driver, particularly with the spotlight from COVID, to look at targeting those inequalities and deliver better care across the system. Finally, we know that there are estimates that 40 to 60% of care home residents show behaviours of concern or behaviours that challenge, and those individuals can place a significant strain on the health and social care system when there are lots of placement moves and indeed admissions to general or psychiatric beds. Next slide, please. Now, in terms of some of the policy drivers, we know we had the updated NICE dementia guidance in 2018, and that had, again, an emphasis on psychosocial interventions and aims to reduce antipsychotic prescribing where possible. We also know that the quality standards that were published the following year really promoted a thorough, holistic and therapeutically informed assessment for those people who have behaviours that challenge in dementia. And there's a real emphasis in those quality standards on meaningful activity and engagement. So we know there's a significant role for mental health staff to play. And I'm talking here about psychiatrists, psychologists, mental health nurses, and indeed occupational therapists coming together to deliver this holistic package of care that we're aiming for. Finally, just to say, the Positive and Safe Agenda was launched in 2014 by the Department of Health, and this had a real emphasis on improving quality of care and reducing unnecessary restrictions. And within that, positive behaviour support is the recommended approach for supporting people with behaviours that challenge, and this includes individuals with dementia. So that was a real landmark moment too. If we go to the next slide, this might be quite hard to see, so my apologies for that, but this is a really helpful step care model that we've been looking to embed within Surrey and Borders for a number of years now, really thinking about how we approach behaviours that challenge in dementia and what we might expect from people in primary care and GPs prior to referral to the community mental health teams for older people. So what you'll see on this slide is that we have two tiers, tiers 1 and 2, which are very much targeted at the primary care level. So this is where we would expect the GPs, care home staff and family carers to do health promotion, identify physical health difficulties that could be the cause for challenging behaviour in dementia, and treat those conditions where identified. At the tier 3 level, which is where the mental health team sits, we're talking about protocol-led interventions. And what we mean by that is that we tailor and adapt evidence-based practice and resources to the unique individual that is referred to us and give advice and signposting around mental health needs. At the 4th tier, the more specialist tier, we have the expectation of greater detective work, as I would call it, so more specialised, formulation-driven interventions that require a bit more thinking through what's the driver and the function of that behaviour. So if we go on to the Surrey landscape, we have a population in Surrey and North East Hants of 1.1 million, and our estimates are that we have nearly 300 care homes just for older people. Of those, 97% are private providers or independent providers, so very few are local authority owned. And we also have some recent figures that suggest around 450 admissions from people living in care homes went to our general hospitals in the past year. So that cost the local health economy in excess of £2 million. We also know when people with dementia are admitted to general hospital, they stay for much longer and they have poorer outcomes on a range of metrics as a result of the feeling destabled by the move. So it just goes to show that it really does pay to invest in these services, and we need a longer term solution to this dilemma. So just to say a few things about Surrey and Borders and the journey that we've been on. I think the journey has probably been going on for longer than 2014, but perhaps that's my best memory of when it started. So in 2014, we set up a supervision group, which was led by myself and an occupational therapist. And we had what were called at the time Challenging Behaviour Champions in a number of the community mental health teams for older people. And we just started with a supervision space and some CPD for those interested clinicians doing this work as part of their CMHT roles. In 2015, we as a trust really engaged with the positive agenda, and that led to us rolling out positive behaviour support plans across the system and within older people's mental health as well. In 2016, an opportunity presented itself because we had the closure of a 16-bedded continuing healthcare ward for people with dementia. And these individuals often stayed on the ward for quite some time due to a dearth of placements to meet their needs. So there were people who had very complex needs, 117 aftercare, continuing healthcare funding. And the commissioners wanted to shut that ward down and instead invest in a community-oriented service, which was called the Intensive Support Team, for people with behaviours that challenge in dementia with the most complex needs. So we started with 7 clinicians, one of whom was an admin, and within 9 to 10 months we'd recruited to the full service of 17 clinicians and had a sectorised model across the system. And this was very much set up as a step 4 service, that most specialist here, with referrals coming from the community mental health teams for older people. And we set up our service with the Newcastle model in mind, with PBS plans as our main goal in terms of care planning, and I'll come on to that in a moment. In 2018, we had a little bit of a shift in emphasis. We had a remodelling within the division, and that led to 80% of the resource that had been commissioned moving into the community mental health team for older people. So moving into bolster and improve step 3 to hopefully offer a more localised and proactive service to the care homes within each of our regions. We then had the step 4 level service retained with a band 7 or 8 psychologist or occupational therapist in each of the 6 CMHTs across the trust, and access to consultant nurses and psychiatrists for supervision and support at that more specialist here as well. Thank you, Rachel. So just to say, in 2020, we have seen a significant additional investment from within the CMHT budgets. And we now have 30 clinicians who are doing dedicated care home pathway work. I can't name them all, but there are a range of roles from band 4 assistant psychologists up to lead psychologists, lead nurses, and so on. And how fantastic to see that level of growth in such a short space of time. So everyone that works into our care home pathway function receives dedicated CPD and supervision, and we've really been working towards improving our local links with physical health colleagues to join the dots between services. Also, just to say that we were successful in winning the Royal College of Psychiatrists Team of the Year award in 2020, and that was a really proud moment for us to receive that award just last month. Okay, just a couple of slides. I think I've alluded to this already in terms of our referral criteria, but just to say that we do expect prior to referral to the CMHT that there will have been some form of physical health MOT and treatment of any conditions that have been identified. We know pain is a massive factor for behaviours that challenge in dementia and can explain as much as 50% of cases. So we really are looking out for that at the screening stage, the referral stage. We also ask the homes to keep ABC charts for a couple of weeks before we come and offer an initial assessment. So in terms of our philosophy and what we're all about as a care home pathway function, really our ethos is in line with the work in the Newcastle group, that all behaviour has a reason and a function, and it involves exciting detective work to find out what the reason is behind the behaviour. And often it's not just one thing, it's a multitude of things that we need to unpick to support that person and their quality of life. We know that behaviour is driven by emotions, frustration, and unmet needs, which are on this slide for you to have a look at. This is the most updated list from Professor Ian James, who works up in Northumberland, Tyne and Wear. And he suggests that all humans have 8 needs, which are described on this slide, that we need to satisfy to have a degree of quality of life. So when we're looking at a referral for someone with behaviour that challenges, we need to turn the dilemma on its head by asking how are they doing with meeting these needs, rather than just simply looking at eradicating symptoms. So on to the next slide. Thank you, Rachel. This is just an example, a screenshot of our positive behaviour support plan, which is what we seek to develop for people with more complex needs and presentations. You'll see that we have a very simple care plan so that the staff in the care homes want to pick it up, want to read it, and hopefully it makes sense to them in their busy roles. So at the top of the page, we have this traffic light system within positive behaviour support, where we try and describe how that person presents when they're in a state of well-being versus distress of differing levels. And at the bottom of that first page, what we can do as a staff team to best support them, things to do, things to avoid, and so on. So this is a really important document, very simple, very attractive. And the emphasis here is really on quality of life and well-being, as I said on the previous slide. I think we really do require a thoughtful and creative approach to develop psychosocial interventions, and I'd be delighted to come back on another day and talk a bit more about how we do that in mental health, because I think we have significant skill and expertise to bring to the table. So my final few slides, just to move us on, thank you, just to highlight a couple of challenges and reflections on this journey, which has been a long one, that's for sure. I think we know that care home systems are generally not receiving sufficient resource. And what can happen then is that the CMHTs spend too much time focusing on that step 2 work that physical health colleagues should be doing and sorting all of that out, when really we should be using our skills to do that step 3 and 4 work. And unfortunately, that can create a bias towards prescribing medication and firefighting, crisis management, which we really don't want. We want this proactive offer of care and support. And that in turn can lead to unnecessary admissions and placement breakdowns when the care homes don't feel held and supported. So this is my penultimate slide, just to say perhaps this is a bit of a model for us to aspire to. And as I'm talking through this slide, it might be useful to think about where you're up to in the places that you work with this hierarchy from blue to gold. The current provision, perhaps in many areas, is that we have lots of clinicians working with great skill, experience and passion, but perhaps at risk of silo working. And that's a concern, because we can't do this work just as mental health or physical health. We and learn from each other and collaborate, which moves us on to bronze. Here we're thinking about having properly commissioned care home pathway services within our mental health teams, where we have good links, good local links. We've reached out to our colleagues, the experts in physical health in the community, our geriatricians, matrons, and so on. If we go up to silver, we're talking about joint commissioning here, which would be the ideal, I think, where we could have support to commission physical and mental health under one roof in one team, and perhaps thinking about offering joint clinics between mental health and physical health, so that we are truly delivering that holistic assessment and approach that is necessary. And gold, right at the top of the tree, is really about all of the things I've discussed below, but perhaps we look at a programme of training and coaching for care home managers, where the turnover is often a concern. And if I'm honest, I think we would have to ask the care home providers to purchase that tier of gold. So I want you to think about where you're up to. I'd like to think we're certainly at bronze and getting into silver in Surrey. And really, we may not be able to get to gold, but even if we could aspire to go up a level in the places where we're doing this work, that would be a great starting point. So thank you for listening. And if you have any questions, I'm happy to answer those.
Katie, thank you very much. That was really informative and obviously a really good reminder to us the role of behavioural support and as an impact on care home residents. We do have a couple of questions within the chat box actually from Sorja. She's asked whether what proportion of challenging behaviours can be moved, can be, I presume, prevented from this input, or actually moved from step 1 to step 2 to step 3 to step 4.
So sorry, I'm not sure if I properly understood the question. So is it about how we can get people out of the system so that they don't need our help anymore at the mental health team level? Is that the question?
I think that's what's yes, I think that's right.
Okay, I mean, that's the ultimate goal, isn't it? I think what we want to achieve is to upskill the care homes. That was the vision of the service spec when this team was commissioned, so that the staff feel able to better manage, and perhaps they then don't need to refer other people in the home, and they can transfer the skills. But I think what happens is often the turnover is so great in these independent providers, even at the managerial level, that we do have to keep going back and issuing the same advice and guidance. And so that's what we're aspiring to. But because of the reality of the care home sector, we don't always get there. But I think there's something about upskilling GPs, talking to GPs. It's great to see Sophie Norris here today. We've got some fabulous leaders who really care and really want to champion this cause and understand, and so it's about making those links, isn't it, with the GPs in primary care and the nurses who are experts in primary care too.
That's absolutely great, and I think that leads on to the next one. I think there's a sort of a theme here. Obviously, it's supporting care homes to be able to deliver personalised care. Is that something? Is that going to create an ongoing? Is it sustainable input? You have to keep providing that training and education, and then somebody else has rightfully said actually there's a lot of influx of training and for care home staff. But how can we engage the care home staff to, I presume, to engage with it, and also to work with our care home professionals together to help people with their complex needs?
Yeah, I mean, I think training, I mean, Jane Fossey did a really important piece of work with her randomised controlled trials in Oxford. And, I think training in itself isn't enough. It's about that coaching. And I guess that's in the bit of gold of the pyramid that I presented. But I think that's where we need the ongoing coaching and the application of that learning in vivo for us to have success, in my opinion.
Fantastic. Okay, thank you. I think we got Jane with us today, actually, so that's good.
Wow.
so that's good. So maybe we can hear from her later. And then, sorry, we've got a few more comments actually coming in, so that's fantastic. So I'm a commissioner from a team in Surrey. How can we work more closely to look at the care home pathway for an adult social care funded clients? We're keen to explore ways of opening up more options and choices for people living with dementia, but finding it difficult to source. That's a big question.
I think it's a big question, but it's lovely to hear there's a willingness. I mean, I think we've got the infrastructure here in Surrey to build on, and obviously lots of tweaking of the model over the years. If you wanted to get in touch, I'm happy to have a chat with you, and perhaps I can link you into a couple of other people who could think this through, with you, because I'm very mindful that the original commissioning was for those people with the very complex needs. And we do have a gap in being able to extend it to everybody, even with our attempt to shift most of the resource up to the CMHT level. We'd be really keen to collaborate and look at that with you. So get in touch. It'd be lovely to hear from you.
And my final one from the chat box: who should be part of the integrated care team for the care homes?
Ooh. Gosh, I bet there's some people who'd like to answer this and probably do a better job than me. I mean, I think for me, what's been absolutely fabulous, I work in the Frimley system, has just been linking in with people like the quality lead, Sue Langan's on the call, hi Sue, who run the care home forums, and we've delivered some training together in the Frimley system. I think we definitely need dedicated care home matrons. I think they're fabulous. I can't praise them enough, and it's great to see some of those new roles popping up. We need access to geriatricians, psychiatrists, and I think we do benefit from having district nurse support. But what's been lovely in each area, we just got to tap into the local resource and learn as we go. So in Surrey Heath, we have linked in with our Parkinson's nurse, and that's brought new reflections and learning. So it's probably a case of just gelling and making those local links and learning from our respective boroughs to agree the final recipe. But I'm sure other people could answer that far better than I. I've done my best.
No, I think that's a very good answer. I'd just like to add as a final point, sorry, is that I think it would be really helpful. I think we've got PCN care homes, obviously teams and leads now, and actually as part of that is the multidisciplinary approach, and I can see this could be a really useful thing to consider. In part of that is that certainly how to support personalised behavioural support. Yeah. Thank you. Oh, and Jane, there we go. Jane's here. She's developed an online version of materials. How about that? So, and she's also got a link to a wheeled study for people who may want to consider, which is all about behavioural support. So fantastic. Lovely. Thank you very much. Well, thank you for that. That was really interesting. So obviously, please feel free to ask any more questions as we move along now. But thank you, Katie, for that. That's really food for thought. So we're going to move now on to our next item of the agenda. So I'm delighted to now introduce Jenny Hall, who works in Buckinghamshire and is Berkshire, not Buckinghamshire, that's me. Berkshire. In Berkshire, and is a real champion herself for developing Dementia Champions as part of the Integrated Care Home Support Team. So over to you, Jenny.
Hello, hi everybody. It's interesting because our team is very much a model of what you've just been talking about. So hopefully we should answer a few of the questions that have come up before. So Rachel, are you in charge? Are you the big cheese in charge of everything? Okay. So I'll just briefly give you a bit of a lowdown of our team. So we are an integrated care home team across the west of Berkshire. So that covers Reading, Wokingham and Newbury and sort of surrounding villages. Each locality has a proactive team and a reactive team. The proactive team consists of RGNs, RMNs, OTs, physios, speech and language therapists. And we kind of focus on education, upskilling, clinical support, coaching, all of that stuff. And the reactive team are a bunch of very skilled advanced nurse practitioners. We've got a couple of geriatricians, we've got 2 pharmacists, and their focus is picking people up and keeping them in the home, treating them in the home, rather than going into hospital. So we do IVs, you know, subcuts, etc. Very, very thorough reviews. So we basically try and keep people away from hospital unless they fractured, is pretty much why people end up going back in. So initially it was set up in 2013, and that was primarily looking at dementia, and that we were funded by the Dementia Fund. And then the CCGs decided that they were going to commission this service. And then in 2017, the advanced nurse practitioners and the reactive side of the team joined up with us. So we're now one big multidisciplinary team. Next slide, please. So part of my role in amongst all of this was to identify that when we were doing training, as we said before, you can have training up the yin yang, but is it actually ever taken, you know, onto the shop floor? And one of the things that we picked up was the fact that the more we got to know the homes and the more we got to know the residents, training was actually much more effective if we were taking the patient or the resident as the centre of the training. So when we do sort of tier 1 dementia training, we've got lots of examples within the home of people and people that we know. So actually the carers started to trust what we were saying. They knew that we were coming in and not monitoring them. They knew that we were coming in to help. And the more those relationships built up, the more trusting they became of our advice and the more things they were willing to try. And what we recognised is that you always have those people within the home who are extremely good with people with dementia, that manage people very well, that have a very person-centred approach, but actually they're not recognised for that in any way within the home or outside the home. They're just known informally as, you know, or go and work with Jean, she's really good with Barry, she can, you know, get him dressed in the morning and things like that. So actually what we decided to do was create a pathway so these people could be recognised. And one of the reasons for choosing sort of the champion model was a sort of train the trainer. So I train, you know, the people that are identified as being very person-centred, and then they can pass on their skills. This helps with the high turnover of staff, because the more new staff that come in, it's up to the Dementia Champions to kind of get them on board. And then if they need extra training, that they can contact me. But also a lot of our carers move between home to home. So once they're a champion, they can go to the next home and be a champion there. So they're taking that sort of credit with them, I suppose. So it's very much acknowledging their skilled workers within the home. They became role models. They became people that introduced new staff to the, you know, to caring in general, as well as to the home. And also they became a single point of information sharing. So if I want to get any new information out regarding dementia care, I can go to my champions and then they disseminate it to the home. Next slide. So our initial training was the Tier 1 training, and that was devised by the Dementia Academic Action Group, the DAG group. So that included Oxford Brookes, University of Bedfordshire, Northampton and West London. And this was 2-hour training and was also in line with the Alzheimer's Society training. So it means that those people were accredited with a Dementia Friends badge after the training. So it kind of gave them a little bit of an extra motivation, and the homes liked that because then they were a Dementia friendly home. Next slide. So we devised this very posh little book, so everybody knew that it was a formal thing, and we wanted to make it formal so people took it seriously. So we developed this Dementia Champions handbook and got our trust to print it out for us. Next slide. So the pathway showed 5 steps. So step 1 was either somebody had a care certificate or a level 2 in health and social care, just because we needed people to have the basics there as well, because there's a lot of people that kind of have very good approaches with people with dementia, but actually then they're missing out on their care skills. And if they're supervising new staff, we need them to be teaching all the practices in a good way, not just, you know, how to speak to people. Or there's somebody who's been identified by the home manager as having an exemplary approach. So often you find the older carers who are very, very good with people with a very advanced dementia haven't got certificates because that's not, you know, in their age target really, and they don't want to do that. But actually they're exceptional carers. So then we ask them to just apply to the home manager, approach the home manager to become a dementia champion, and we gave them sort of kind of a job description for them to talk to the home manager about. And then they meet with us for the 2-hour training using the DAG training. And then ongoing from that, what we tend to do is we make monthly contact, either using face-to-face supervision or a supportive chat. We do education slots once every sort of 3 to 6 months. And also I send out a monthly email with just something interesting written on it to all my champions, so they can have a little read, or, you know, something new that's come out, so they can read that once a month and also disseminate that if they want to. And then there's a bit at the end of the booklet that talks about self-reflection and evidence of their own self-development and project work within the home. Next slide. So the job description helped to add a sense of formality, which I've said. It helped with commitment of people to engage in the process, and also meant that managers could pull people back in and say what's happening about this, what are you doing, you know, you've had your training, you've been singled out for this, you know, where are you? It also assisted with mentoring new staff, allowing them to have time set aside to do things that they want to do, so project time, and also gave them permission to liaise with me in the care home. So they could send me emails and say, we're worried about this chap, he's behaving like this and we're struggling to help him and stuff. So it kind of gave them an access to me directly rather than having to go through the seniors or through the home manager, which was good. So they're just examples of the pages in the book of the reflection template, any ideas for project work, and then the progress sheet summary, so they can fill that in at the back about what they're doing. Then we gave them a badge, because that's very important, I feel, having a badge to identify that this person you know, has been singled out. And as much as we laugh about that, actually everybody likes a badge, and they laugh about it, that they like a badge. So they get 2 badges after doing the training, their Dementia Champion badge and their Dementia Friends badge. Next slide. So the aim was we were going to have 1 Dementia Champion per 20 residents in the homes. That was kind of, you know, plucked out of the sky. But not all the homes wanted champions. Some of the homes, like Bupa, had their own Dementia Champions and their own pathway, which was fine. Staff turnover is obviously a big issue everywhere. It's quite difficult sometimes in securing 1 to 2 monthly supervisions. Getting people, you know, to take time off and come and sit down with you is quite tricky. However, the more we get to know the homes, the better that's become, because I think the more the champions have realised how valuable it is, then they make time, which is great. Managers being absent, so the Dementia Champion role is just not supported, and also just managers not being on board, not wanting more people in their home, feeling that we're criticising, and quite often the care staff would want support but the managers don't, and that's quite tricky. Next slide. So as I said, monthly email with latest research, interesting reads, occupation, activity, 1 to 2 months booking time with the champions. We also do a lot of support and education with them about physical health as well, because the team's now expanded. The champions can ask to learn about anything, so you know, we can access the OT, the SALT, the you know, the physios, and our physical health nurses, so anything that they're interested in. So we have done teaching sessions on Parkinson's and, you know, medications and things like that as well. So it's not just solely around dementia, it's about how dementia interacts with that person's physical conditions. Once a year we've been holding a Dementia Champions forum, so we've been getting people together, which I think the next few slides talks about in a minute. And also we keep the champions in touch with each other, so they've all got each other's emails and they give us permission to give each other's emails so they can share ideas and get support from each other. So the Champions Forum, so far we've had 3. One was the first one was a pretty full day in a room in a care home, and the general sort of format of it was looking at the celebration of achievements. We did a training session on oral health, nutrition and hydration, and then we looked at the confidence levels of people talking to other people, i.e. managers and seniors, about how to kind of bring about change and the challenges in the homes that people face and planning for the future. So we kind of did a bit of personal work with that. The second one we held in a pub, which was much more successful, not just because it was in a pub, but the fact that there was less distractions, because we found having a room in a care home was actually quite disruptive and we were distracted quite a lot. So we had it upstairs room in a pub. It was again another full day, and we looked at advancing dementia, biology and brain changes, and the concept of intensive interaction, so more towards advanced dementia and kind of how people have managed that. That was really successful. People loved getting out and going to the venue and being given permission to not work for the day, and come and look at things a bit closely. They really enjoyed that. So the third one we held in the same pub, and we focused then on physical health, and we looked at personality, and we also looked at social aspects of the person and the social environment, which again was great because it was getting people to look at how physical health affects somebody's dementia and behaviour, and what they can do and what they have to do to escalate that information. Next slide. Yeah, there's a couple of pictures of us doing some marvellous work. So the picture on the top to the left is we devised a snakes and ladders physical health game. So people had to, you know, answer questions about physical health when they landed on certain squares. And then the photo below that was the environment and designing their own environments based on what research suggests for people with dementia. And the image on the right was just about getting people to think about the different parts of the body and what can go wrong and how that can affect the person. Next slide. So currently, out of the 52 care homes in the West of Berkshire, we have 48 champions to 2,520 beds. So our ratio is 1 in 52. So it's quite a long way short of 1 in 20. And out of the 52 care homes, 31 of the homes have Dementia Champions. I have to say that there's a chunk of homes that just literally refuse to engage, and there's a little chunk of homes that are Bupa homes, so they have their own champions. So actually, you know, you're probably talking 1 in 46 probably homes, rather than 1 in 52 ratio. So yeah, that's probably the case anyway. Next slide. So during COVID, the aim has been to try and maintain contact basically and just offer support however we can. So we've used team meetings and support rather than actually turning up in the home, although to be fair, our team is probably the only team that is going in to the care homes. So actually they haven't stopped us going in because everyone else has stopped going in and we're the only ones visiting. We've used Teams now for training in Tier 1 for new champions and for new staff, and that's been really successful. And we've also developed the Advanced Dementia course on Teams, which I initially rolled out about a year ago for relatives in one of our care homes because the relatives were asking for it, and it was a 5-week course, very well taken up. And then they wanted to roll it out to another home up in Stratford, so they wanted it online. So I did it as a link, you know, so the slides and my lovely voice comes rolling out over the slides. So they've taken that on board, and I've used it a couple of times with other the Newbury College and things like that. So the college people have taken it on board as well. And the Advanced Dementia course basically looks at the brain biology, communication, sensory in the environment, and behaviours that challenge an end of life. So it's kind of 5 different slots each, if you teach them, about an hour long, and looking very much at advanced dementia rather than early stages. And we also developed a delirium Teams presentation, so getting that out to all our care homes during COVID is obviously very important at the moment. So care planning support has still been going on virtually and face-to-face. For the last 2 years, we've been doing sort of clinical review meetings with homes, where we've sat in sometimes with the GP, sometimes with one of the RGNs from the team, sometimes with the speech and language therapist, depending on what the home needs, and doing sort of clinical review meetings once a month so we can identify people who are at risk and try and help them manage changes in health. Also looking at not for resuscitation forms, respect forms, you know, advanced planning and things like that. And we've also done some Teams online verification of expected death training as well, and signed off competencies and things for the home seniors to be able to verify death. So it's been a busy year. Next slide. That's it. I've come to the end. God, I would have kept going then.
Jenny, that was fantastic, and I think it's really highlighted actually the acknowledgement of people with specialist dementia skills actually does have its rewards, and the peer support that you've been able to develop to really do that in Berkshire has been fantastic. Can I just double check then with the accreditation, who after going through all their steps, who marks them to say they are ready to be accredited, or is it a self-accreditation type phenomenon?
It's a self-accreditation, really.
Yeah.
Yeah,
okay.
So as long as, it's a self-accreditation. I mean, that's why we kind of have monthly support and we keep up to date with the managers and things, because if they feel that the Dementia Champions are not doing what they would expect them to do, then they can withdraw, and take the badge off them.
Sure. And have you got, I mean, obviously it sounds that you've got really good, you've actually managed to get into 48 care homes, which is amazing. Have you seen a difference with outcomes at all in the care homes that you have managed to obviously to support with the Dementia Champions?
Yeah, definitely. So I think the one thing, because I've been working in this team for 7 years, so I've seen the kind of difference between 7 years ago and what we've put in place now. I think that the biggest thing is the confidence to try different things. So we are finding that the care home staff are much more confident at trying something. When they're coming to me, they're saying, we've done this, this isn't working, now I need you to come in. And that's significantly changed, which is quite difficult to measure. We have previously tried to do confidence surveys, kind of before and afters. We obviously do that with the training before and afters, but so that's quite an obvious measure, but it's not a numbers measure. I think the whole team has reduced admission rates into our Prospect Park, so our psychiatric hospital. So that's reduced, which is, there's so many variables for things like that, isn't it? So that's quite difficult to prove again, but with the reactive team on board, quite often the soft signs of people becoming unwell that usually would have gone back to the GP, and then the GP would have referred on to psychiatry, and then by that time they were septic and in hospital. What's happening is that the champions and the staff are picking up on those soft signs a lot better.
Right.
So they're getting people seen earlier.
Yeah.
And that's been a big change.
And just a final question is, because it sounds like then, just with regards to the homes, you've got good engagement, but recognise this, it has been tricky for some others. Are there any plans to try and engage with them now?
We are ongoingly trying to get our foot in the door.
Fair enough.
Do you know what the problem has been, and I can't stress this enough about our team, is that I was here in the beginning in Newbury, and so I've consistently been in Newbury for 7 years. All of my homes engage with me. Right. In Reading and Wokingham, they've had a change of teams, like on and off over the 7 years, and that is where they've had more trouble getting in, because there's been a lack of consistency. Sure. And sometimes it's very much about personality as well. There is, some you have to pick quite carefully who you're going to choose to be your care home support team workers, because that ability to be amenable, to be flexible, to sometimes close your eyes to things, not, dangerous things, obviously, but you're not there to monitor. You're not, there's enough people doing that out there, and we're very clear about the fact that if we find something concerning, it is for the home to raise with safeguarding and care concerns, not us. We're not going to go behind their back and do it. It's very much, we are handing responsibility to them to take control of that, because they've got CQC, they've got care quality, they don't need another bunch of people coming in and telling them off. No. So it's very much about coaching, supporting, and not, having a go at them.
Very much, Jenny. We're going to have to stop that now, yes. But thank you so much. That was very very informative, and obviously once again highlighting the power of champions. So something for us all to consider on our other areas, how we can promote that network and that peer support. That's fantastic. So if we could just move on now, so to Dr. Katie Kerr, who I'm delighted to introduce to you today, who is a regional dental advisor in Thames Valley, and has come to talk to us today about the importance of good oral health in patients in care homes, and of course those with dementia. So over to Katie.
Oh, thank you so much, Sian, and I really do appreciate the opportunity to present today. And it's been fascinating and really interesting to listen to the other speakers. Thank you so much, Jenny, that your first session was oral health, nutrition and hydration. I love it. That's absolutely fantastic. And I think that those three things have really been identified as very important and very linked together. Obviously, this is a whistle-stop tour through, a very quick update. My contact details are at the end, and I'm very, very happy for people to get in touch if I can help in any way. So next slide, please. Thank you. Thank you, Rachel. So we know it's very difficult for people with dementia, namely to remember to brush their teeth, so they're far more likely to have oral health problems. They're also less likely to access services, so they will have a much higher need. And the impact then on their well-being and general health is huge. We know that there's a whole body of evidence that shows that the bacteria in the mouth are implicated in aspiration pneumonia, which is the leading cause of death. And both pain and infection can, of course, decrease cognitive function. So whilst it's important for everybody to have good oral health, it is particularly important for older people. And I'm mindful that people in care homes, it can be a reason why people do have to go to hospital for a general anaesthetic if they have got oral problems. And with what Katie was saying earlier about then the difficulty is that will they actually cope well and be able to come back into that care environment. Next slide, please. Thank you, Rachel. So this is a diagram really showing the link between health and cognitive function overall. I was delighted to see that it actually was in a nutrition document, but it just highlights the link really through tooth loss, but also through systemic inflammation due to gum disease, and that these both have an impact then on somebody's overall cognitive function. Next slide. Thank you, Rachel. So dental disease, there's a myriad of things that can happen in the mouth, and particularly older people are more prone. We tend to produce less saliva as we age, and so we are more likely to have issues and more prone to things like infections like thrush as well. But the good news is, just click, thank you, Rachel, is that dental diseases are preventable. But we have to do two things. It's around our oral hygiene and our diet. Next slide, please. So there are some basic measures that we can take. If I had an hour, I would spend a little bit of time, but I rather like this infographic, which has been specifically put together to try and highlight that oral health is very important for people with dementia, and some key things that that can be done to help. The first one on the top right is talking about limiting sugary intake. We know that the number of times somebody has sugar does affect their likelihood of getting decay. But I think we must, and I must highlight that actually there will be people with dementia who, for a variety of reasons, will be consuming sugary foods frequently through the day. And that might be through their nutritional needs or their personal preference. So a key message that I'd like to put across today is that actually we need a really holistic approach to that, and that we need to put things in place and care plan to make sure that we're giving them the oral care that will help to mitigate that risk from that increased sugar. So yes, we won't dwell on that too much longer. Next slide. Thank you, Rachel. I thought I'd put this one in. There has been a lot of talk and debate about caring for people who actually have COVID. And I've had quite a few emails saying that actually people are challenged by whether it's appropriate to be giving mouth care, or those that are in intensive care, that actually they're having significant problems with their oral health. So these are some guidance that have come out from Public Health England, and I'm happy to circulate them after the meeting. The main things to consider is that they are more likely to cough, and therefore we have to be mindful of that. And so it's the only time that we wouldn't suggest that using an electric toothbrush would be appropriate. It's better to use just a normal manual toothbrush at that time. And obviously everybody would wear the appropriate PPE. Thank you. Next slide, please. So as Katie was saying in her talk, the link between pain and behaviour is quite clear, and so it's just being mindful that the pain might be generated from the mouth. So it could well be a reason why somebody's refusing to have their mouth cleaned, because actually it's feeling sore or uncomfortable. They might have swelling or infection. So I would just urge people to have that at the back of their minds when they're seeing that change in behaviour. And to document and report. It's really important. I'll talk about the NICE guidance, but it's really important that we're documenting mouth care to prevent that. Next slide. Thank you, Rachel. Often it's about having the right products as well. I just thought I'd put this one in. I'm aware that the slides are going to be available through the network, so I thought I'd put a range of information that might be useful for people. But certainly, time we get to late stage dementias, we're probably far more likely to have dysphagia and swallowing problems. So we want to be very careful about what we use. So the top toothbrush is actually one that can fit onto an aspirating unit, if that's available, or the second toothbrush is a very tiny little, it's called an Aura Care Mini, and it's a very small toothbrush that can reach into the mouth even if somebody can't open very well. At this point we would recommend using a dry toothbrush and just putting a small amount of toothpaste so that it doesn't splash. And Aura Nurse is a nice toothpaste because it doesn't foam and it's got no taste. And so that's really helpful for some very dry, sore mouth. Thank you. Next slide. So that was kind of a whistle-stop tour just to give some background so I could talk about teeth. Now I'm just going to focus on the main purpose that I'm talking today, and that's looking at some of the relevant guidance relating to oral health. So the NICE guidance came out in June 2016, and that was the expectation that care homes would have policies, they would be assessing mouths and producing mouth care plans. They were keeping documentation of the mouth care they deliver, and they were making sure that staff was receiving training. Next click, Rachel. What gets lost a little bit in that is that there actually was some guidance around dental care provision, and so some guidance for dental practitioners. And this sentence that's in blue here really is quite an interesting one, because this is what the NICE guidance says: provide residents in care homes with routine or specialist preventive care and treatment as necessary in line with local arrangements. And what we find across the southeast is that there aren't really any arrangements, so that is not happening currently. So I'm part of a working group that's working with the Office of the Chief Dental Officer at the moment. And COVID's given us an opportunity to actually review how dental care is provided. And so from next April, we're hoping that we can have some flexible commissioning models that can be picked up by local areas to actually commission dental care for care homes. So that the work is going fast, and hopefully that will be together, as I say, by April next year. Also within that NICE guidance, it's asking dentists to preferably make 2 sets of dentures, but also to make sure they're appropriately marked with the person's name at the time of manufacture. manufacture, which would be hugely helpful because we know lost dentures are a huge issue. Next slide, please. So that guidance came out in 2016. During 2018, I sat on an external advisory group for CQC, specifically looking at oral health in care homes. And from that probe, we got the report called Smiling Matters that came out in June 2019. John Milne, who leads on dental matters for CQC, it actually took him 3 years to get the Department of Health to give permission for that probe to be undertaken, because if we find that there are issues, then they're going to have to address them. And so a lot of the momentum for moving forward with oral health has come from that report. Next slide, please. So the recommendations that came out of that were that we should be sharing best practice and we should be having a more consistent approach. So a new group was generated, the initials are AO-HOG, but that's the Adult Oral Health Oversight Group. And in fact, we've got a meeting this afternoon. And that's looking very strategically at how to bring all the key stakeholders together from the Department of Health, Office of Chief Dental Officer, the faculties, the British Dental Association, Health Education England, Public Health England, and NHS England, so and lots of others. So really key strategic group, and that's been hugely influential in moving things forward. There are some other guidance. I've put them in blue, and these are some of the things that I've been working on as part of my work streams. I'm very aware that in the chat, you're quite right, there's been a whole influx of mandatory training, but this is another one in the list. So it has moved now to be mandatory training, to have training in oral health. And as I was saying, we're trying to look at improving that access to dental services as well. Next slide, please. So to support care homes and to really make it very accessible, we thought that actually having access to free training and to have all the resources in one place would actually be very helpful. So I'm pleased to say that on the 27th of November, we launched this new Adult Oral Health in Care Homes toolkit based in Public Health England. So it's designed so that there are 3 different sections. So there's information for commissioners, there's information for care home staff, and there's also information for residents and carers. We've just got agreement that actually we will continue to build the toolkit. So next year we're going to build dedicated resources linked to dementia. There are some there already, but we're going to make that more specific. And also we're going to add in a whole section for members of the dental team so that they have all the information they need to support the Enhanced Care in Care Homes programme, because obviously there's an oral health element to that. And that's also part of the flexible commissioning contracts that we're looking at, how we can help dental care professionals provide that. Next slide, thank you. So for the care home staff, we've got a whole section on the NICE guidance and how to actually go about complying with that. So it's got template policies in there, it's got assessments, it's got example care plans, so everything that a care home would need if they haven't got those resources already. But it's also got an audit tool so that a care home could check whether they have got everything to be compliant. And CQC now are looking at oral health as part of their inspection criteria. And so that would help the care home to provide that evidence. The training materials, I've been very involved in setting these up, and there's a whole raft of different things there, including some pre-recorded training slides, so that a care home could just literally sit and watch those. They've been divided into modules so they can be done in short sections to help. And then there's quality assured other resources, including videos that people can pick up to use. Next slide. So it's really important that we all work together, and I think that's why it's lovely to come and to be part of this sort of event, because having that consistent messaging and all being aware of each other's work is absolutely key. And so I will just keep waving the banner for oral health if I can. And thank you. That's the last slide then, Rachel. Thank you.
Thank you, Katie. I think it's always really good and very pertinent to recognise the importance of good oral health for all of us, but particularly those in care homes. So I think some very useful tips there. I guess the toolkits are now available, and obviously you've put the link. There is a link in the slide. Is that?
It is, yeah.
Right?
It's on the top of the slide. Yeah.
People can just download those. So thank you for that. Obviously, if anybody's got any questions for Katie, then to please let us know. And but it'd be important once again when we go back to our MDTs and our personalised carers, just to make sure that we're not forgetting oral health. I think that's really the key message and the impact that has. Thank you.
Thank you, and I'm really happy to help sort of facilitate that that work, because that's definitely something we're very interested in doing.
Fantastic. Thank you very much.
Thank you.
Okay, so come to the final part, which is actually myself now, really. So it's just a really a quick run through, really, for a toolkit, another toolkit. So I think we'll run through, just summarise some of the tools that we've introduced today that may be helpful to support people living in care homes. So this is called We Check Dementia Care, and this is a toolkit which is aimed for care homes. It is not something to judge them by. It is something that care homes may want to use to really to look at and themselves how they may want to judge their own care, but also how they might want to improve some of their care. So moving on to the next slide. So once again, it's just to say that obviously, so it's really important that having recognised already from the talks today that personalised and care and behavioural support is really important to keep people well in care homes. And so by being dementia friendly can actually enable people to live well and reduce the impact of unfriendly care plans for those with dementia. And so it's important that we can approach this with a personalised care plan. So next slide. So why have we developed a toolkit? Well, it's important because we know that people who are with dementia who are cared well can actually live well with dementia. We also know that 70% of people living in care homes have dementia, yet we know that probably a majority of those are undiagnosed, and this can then of course lead to problems with not recognising that some of their behavioural needs are because of an undiagnosed dementia. We also know that obviously as people progress with their dementia, they can then struggle with communicating their needs and preferences, and it's looking at, well, how can we support care home staff to recognise some of these needs as well. And of course, by doing all of this, we've already heard this quite strongly today, we can if we don't do this, we can find that things can escalate and result in crisis management and of course unplanned admissions. Okay, so next slide. So the We Check Dementia Care is a toolkit for care homes. The top half of this slide shows you what the toolkit looks like, and I'll run through how to use this in a second. The final, the grey blob really sort of on the final right hand corner of that toolkit has got the tools which are needed for the care home, which includes a self-assessment questionnaire, access to the toolkit, as well as a template for the care home to produce their own action plan. And we put the link on here, which is the We Check Care toolkit and templates that people can download the toolkit for themselves. Next slide. So as I said, this is the purpose is for the care home, and really it's to look at drawing together lots of different standards, which I know are all thrown at care homes at the moment, but maybe this is something that can just try and bring all of this together, that will satisfy people who are looking at how they're performing care. But this is, for us, we've drawn together the standards from NICE, CQC, and also aligned this with the NHS Enhanced Care Framework. And by doing so, we have developed, we've subdivided it into 11 key areas. We won't go through them all, they're listed on there. And those are the key areas we'd like care homes to really objectively self-assess themselves. How are they delivering the care in this? You may notice that the first letter of each of those words on the 11 key areas would then spell out "We check dementia care," so an easy mnemonic. Next slide, please. This is just a quick one, just to say, so the process is for a care home to really complete the self-assessment questionnaire, then to reflect and consider the areas that can be approved, and then of course to complete an action plan, and then of course, which I haven't put on there, is to review this after a certain amount of time to check that they are delivering on that. So this is something that they would do for themselves. Next slide. This is just a snapshot of the first criteria, the first self-assessment in the questionnaire, which is a well-led workforce, and you can see under that there's some subheadings of some areas that would be considered as good practice, which have been linked, whether that's NICE, CQC or the Enhanced Care Framework, that then the care home themselves would then really self-assess as to whether they felt they were performing well, or obviously felt they needed to do something a bit further, and obviously they can just note what they think they might need to do or not do in the evidence. And so we would expect this questionnaire to be for each care home to self-assess against each of the 11 standards. Next slide. From there, it would be fairly apparent some of the maybe the weaker areas that care homes might want to look at, but not quite sure how to improve it. And this is where this digital toolkit comes in hand. And each of the buttons on this toolkit represents each of those 11 standards we talked about. So if we go to the next slide. For instance, they wanted to look at training for, we've talked about training today, about maybe some training for dementia awareness training for all their staff. We can look on, so they can click on the button for a well-led workforce, and you can see there's lots of resources on here, and including, as you can see down in the right-hand corner, some training opportunities that a care home might want to be able to access. Next slide. And so I won't go through all the buttons, but to all of the buttons, you can then click at the top. You can then go to the coordinated care, and for instance, they may want to know a little bit more about the red bag scheme and how they might want to embrace that. And once again, they can click on that particular component. Next slide. And likewise, the diagnosis of dementia is really important. We all know, unless you have a diagnosis, or rather it's more difficult if you don't have a diagnosis of having the right care. And some of this is just to support the care home as to how they might want to identify those with dementia. So for instance, using the diadem tool or the Dear GP tool, which likewise are on here as well. Next slide. So each of those buttons have lots of resources, and not everything has to be done. And I think this is really important. These are resources which have been collated from lots of other verified sources, which would help with them with their action plan. And this is an example of an action plan that a care home might want to do, which you probably are familiar with, that they can then look at obviously in a few months' time. So next slide. So these are the tools, I think I said at the beginning. So the final blob on the ribbon is the tools themselves, which includes the instructions, obviously the templates we talked about, the self-assessment questionnaire, and as well as action plans. And they can all be downloaded from this toolkit. it can be seen that this tool, as I say, whilst it's a self-assessment, is actually really valuable evidence as well. So if a care home did feel they would like to submit this either to commissioners or to CQC to evidence what they are doing and how they're trying to improve, then obviously this would be a very appropriate way to manage that. And the next slide. And that's it. So it was a real whistle-stop tour, really. So I think that is something which is available now, and it's on the website, on the link, as I say, within the slides. And certainly this might be something that in the areas of your work you might want to encourage people to look at, whether that's care homes, PCN, care home needs, for instance, we've talked about, or indeed even in the care home teams that are supporting care homes might want to suggest that this is something a care home might want to use. So there we go. So I think hopefully that's all self-explanatory. We've got no questions on that, so that's all very good. So I think we'll just wrap up quickly now. So just to say thank you very much, everybody, for attending today. I think we've had some fantastic speakers today and some real food for thought, some really good links and some ideas of how we can support those living in care homes, and of course our care home staff who are doing an amazing job at the moment. We've had a few gifts this week, this talk. We've had obviously talks from about PBS. We've had Jane Fossey with the links to the online training for care homes if they wish to participate, and that's something you might want to endorse. We've had a gift about how to support accreditation with Dementia Champions and the benefit that might bring. Of course, we've had the Smiling Matters and the training that supports for oral health for care homes, as well, of course, as we've had, and obviously the care home toolkit. Oh, sorry, there's a hand raised. Sorry, I missed that. Sorry. So, David.
Yeah, hi, Sean. Hi.
Hi, yes.
Yeah, thanks. There've been some really interesting talks. Great. I love the one about oral care because it's not often talked about. I thought it was brilliant. It was just really the whole idea of the quality, and a lot of this has been talking about quality of care. Of course, the care home places are often commissioned not by health, but they're commissioned by local authorities. They are commissioned by local authorities. And I did put it in the chat, but you know, how much of this is actually sort of covered by contracts and what is required of care homes in terms of quality of care? Because it seems to me a lot of this is to do with commissioning. What do we actually commission, and whose role is it to commission it, and whose role is it to monitor it? And that's caused deathly silence, I think.
I know, I was talking. So it's me again. So sorry, yes, I was just going to say, obviously, yeah, I think it's a really valid question, David, and I don't have, I think you're right, it's complex, and I think it's important within, for those who are commissioning services within care homes, that these are sort of things that are looked at. However, not all, obviously not all of the care homes are commissioned by local authorities. So I think those, I think Katie in the very beginning said only a part, you know, a proportion of the care homes are commissioned. And I think this has been part of the complex picture, is that of course all of care homes are you know, are quite unique, and it's and trying to build a network and standardised good care is something that we would recognise to be of value, really. We would hope that the enhanced care framework would help standardise some of this care, and of course I know that there are care home networks which would also help, but I think the problem is that not all of the care homes are commissioned.
Thanks.
Does anybody else have any other points on that? No. Okay. Oh, Kathy.
Hi, Just to say, I'm Kathy Salmon, I work in Surrey. Some years ago in Surrey, going on what David was saying, I think it is a real issue, and Katie's already highlighted, I think it's about 80% of people in care homes across Surrey are actually self-funded. So they wouldn't be local authority placed. But Surrey, some years ago, following Merrick Park, which was a nursing home that was closed down overnight, Christmas week, with not very good outcomes, Surrey did have a joint quality group between adults through social care colleagues and the CCGs about looking at the quality. And I think it would be a joint up responsibility around the quality, regardless of where the funding's coming from. You know, I think quality should be on all of our agenda, and it should be all the organisations that go towards monitoring the quality of services.
Yes, no, thank you.
Can I just say, we tried in the last 4 years, we've tried to get all our care quality departments together across the west of Berkshire to get an agreement to have, you know, a quality register, basically a tick box thing, and we can't get them to agree.
Yeah, they did go some way in Surrey. I don't know how far it ended up in the end, because I made the mistake of retiring, but you know, they did, you know, they were on board as part of the quality standards, a joint thing, because I just think, yeah, it's a real difficult one to crack.
Thank you. Yeah, they're a very difficult one to crack, but I think we're making ways that we hope that we can support with some of that. But you're right, is how do we bring everybody together? So any last minute questions, or shall we finish a few minutes early? Let me just double check with my chairing. No more questions in the chat room. No more hands. So I think I just want to say thank you once again for attending today. I hope that was food for thought. Thank you for all your support for those in care homes again, and I can only wish you a happy Christmas, and we'll send you a present of the recording and the slides. All right, thank you very much.
Thank you, Sean.
Take care, bye.